Hi, I'm Matt Williams. I'm a consultant oncologist based at Charing Cross Hospital in West London.
And I'm Shivani Soni, one of the senior CNSs.
So we've been asked to go over some of the common questions that patients and carers have been asking in the context of treating people with brain tumours during the COVID pandemic. So I've been part of some national discussions around what we do with brain tumour patients during COVID. So lots of oncologists and neurosurgeons from around the country have been discussing things on email. There's also been some national guidance from NHS England about prioritising chemotherapy, prioritising surgery. I think it's fair to say that given the demands on the health service, it's very clear that the amount of treatment we can offer is going to have to change. So neurosurgery in particular has been quite substantially affected because lots of theatre space is being used to ventilate people with COVID. But we are trying to still offer a service, and so there's been quite a lot of sensible discussion about what could we do that would still be effective, even if it involves patients coming up to hospital less. And at the same time, it's also about trying to reduce the risk. And so probably the big risk is that bringing patients up to hospital increases their risk of contracting COVID, and giving people chemotherapy seems to increase their risk of contracting COVID. And so the amount of chemotherapy we're offering has obviously gone down. And then, of course, we're not treating every patient the same. So for patients with lower grade tumours, we're much happier to say, let's not do anything at the moment, let's delay things, let's not bring you into hospital, let's not expose you to risk, and let's pick things up in a few months. For patients with higher grade tumours, I think we're having to make more difficult decisions about perhaps delaying treatment or giving radiotherapy but delaying chemotherapy. And for patients with grade 4 tumours, we're often having to have very difficult decisions, very difficult discussions about what treatment we can offer, what we should offer, what might be beneficial and what might be safe. Shiv, is there anything you want to add?
No, I think that's fair. I think, it's just key to reiterate the fact that we haven't made these decisions on our own. And as you said at the beginning, I think all kind of the neurosurgical centres are doing something pretty much the same as what we're doing. And decisions haven't been made lightly, because I think a lot of our patients have struggled, especially our grade 4s, with kind of that idea of not now having treatment and changing kind of into that kind of surveillance palliative care. I think in terms of kind of how often we're reviewing things, we've kind of safety netted all of our patients, and they've all been given a form of kind of telephone or VT follow-up kind of going forward, and a plan as to what we're doing. But I think the key thing is to say, if that changes in the interim before then, patients can obviously get in touch with us and give us a call via kind of me as the specialist nurses, and equally we'd encourage other patients to do the same thing, to kind of touch base and say, actually, I'm getting new symptoms, or X, Y and Z are happening. And at that point we then review kind of the capacity and what we can do, and then make a decision at that point, I think is fair to say.
It's a very difficult situation. It's very difficult for patients and for their families. It's also very difficult for the medical and nursing teams. I think we need to be clear that these decisions are not decisions we make lightly. They're not decisions we make on a whim. There is written guidance about what we think we should do because of what we think is likely to be safe, what's likely to be unsafe. And we have to recognise that people are making very difficult decisions in the context of limited information. So what we know about COVID now is much less than we'll know about COVID in 2 months' time. And I think that's very clear. I think at the moment it's very difficult to go down a formal second opinion route. We normally get lots of second opinions, for example. but at the moment we're really very busy, and I think I'm not sure that we can honestly offer a proper second opinion, given how busy we are, and also given our own capacity constraints. So I think for most of the patients where patients or carers haven't been happy, we've discussed it, we've gone back and discussed it again internally as a team, made sure that we really feel that is the right decision, and then gone back to the family and rediscussed it. And in fact, on both occasions I can think of where we've done that, in fact, having had another discussion and gone into it in some more detail, in fact, the family have understood why we've made that decision. But I entirely accept that these are difficult decisions and difficult discussions to have, and we're often having these discussions by telephone or via video phone, because of course we're trying not to bring people into clinic, and that always makes these discussions more difficult. I suppose if you feel that your team have phoned you up and said we should do this in terms of treatment and you're not happy with that, I would encourage you to talk to your treatment team. I think you might be surprised at how much thought they've given it and at how widely they've consulted before they've come to those decisions. Treatment has been postponed or cancelled, and I think my advice is largely when we have these conversations is then to make sure that you stay in touch with your team.
Yeah, absolutely. And I think, fair to say, I appreciate we have already said about the fact that we will go down to skeleton staff and a lot of us will be redeployed, but I think important to say that there will be still somebody kind of manning that number that you have for your specialist nurses, so still to use like that as your first port of call. If you're plugged into other community services, to equally use those. And I think, as I said in kind of one of the previous videos, was monitoring your own symptoms, and that'll be a better indication as to kind of what's happening. And if things are then changing, then to get in touch with your team via kind of your specialist nurse.
Obviously, chemotherapy is an immunosuppressant, so it suppresses your immune system, probably makes you more likely to catch COVID. Some other drugs that we use, so steroids, for example, are probably immunosuppressant as well. But other drugs, so most of the anti-epileptic drugs, don't appear to have an impact on your risk of catching COVID. So you should normally continue your anti-epileptic drugs and definitely don't change those without talking to someone. Steroids are more difficult, so the phrase I use, or we use with our patients, is around we want you to be on as little steroid as possible. So if you don't need to be on steroids, you shouldn't be. But equally, most of our patients who are on steroids need to be on steroids. And some patients will have tried to reduce their steroids and then found that they run into problems. And I think for me, this is about balancing risk and benefit. And actually, for most of our patients who are on steroids, the risk associated with stopping them is likely to be higher than the risk of continuing them. And just to reiterate that no one should stop their steroids suddenly. So if you are reducing your steroids, that should always be done step by step and reducing a little bit at a time. So I don't think there's any specific experience of whether COVID infection would increase your seizure activity, but it is our general experience that people with brain tumours are at risk of having seizures, and if you become unwell with anything else, then your risk of seizure seems to go up. And so I suspect that that's true if you develop COVID as much as it is if you develop anything else. I think those are very difficult decisions, and I think you have to make them on an individual basis. Some of us can work partly from home, and both of us have been working partly remotely, but I can't do all of my job from home. And I think you need to make those decisions on an individual basis, because the worry is, of course, if you're going into work and then you contract COVID, then the worry is that you then pass that on to someone you live with, and if they have a brain tumour and they're at increased risk, that might obviously be a problem.